Hi, I'm Dr. Randy Martin, and we're here at AATS Mitral Conclave 2017. I'm thrilled to be joined by Ralph Damiano, who many of you know, all of you know, actually, in the surgical and the cardiac surgical world. Ralph, you've been a pioneer in educating us about treatment of AFib, the surgical treatment of AFib. I remember some years ago the percentage of patients who had long-standing chronic AFib who were coming from mitral surgery, you said about 40% were being treated. There's been some improvement in that?
Yeah, I mean, it's really a good point. I mean, historically, even though we developed the surgical treatment of atrial fibrillation actually 30 years ago this year, the first case was done in 1987, but despite 3 decades of experience, surgical ablation has been historically underused. The main reason that back in the 80s and 90s was the cut and sew maze procedure, which was the procedure introduced, was remarkably effective with late cure rates over 90%, even out to 5 to 10 years, but was a very difficult, tedious, and invasive procedure, and really was only done even at the height by just a handful of surgeons around the world, and really only several hundred cases a year were being performed. What happened over the last 2 decades now is that we've introduced ablation devices and developed much less invasive surgical techniques that has made the operation and the ablation procedure much more amenable to the whole world of cardiac surgeons.
But if that's the case, why were only 40% of patients being done?
Yeah, I mean, part of it is educational, and I think we saw that many surgeons during their training weren't being taught how to do a maze procedure or surgical ablation. And they also still were under the misconception that this was really difficult procedure and really weren't willing to add it. I think what we've seen, and you're right, with the introduction of the ablation devices to make it simpler, it still just went from, now we made a lot of progress because it went from close to 0% up to 40, and that happened over a 10-year period, which is a pretty dramatic progress in some certain, but still far from where we'd like to be. But what we've seen over the last 4 or 5 years with a pretty concerted educational effort is that on teaching surgeons how to do the maze procedure, that in the last harvest from the STS database, that number in mitral patients had jumped up to about 68% of patients.
That's pretty dramatic.
It's good. Now, you would still argue that we have over 30% of patients not being treated, and I think it's still basically, it comes down to a couple reasons. One, surgeons still are hesitant to add it to a procedure, and also, I think we would like to see more cardiologists actually demanding and asking for it. And part of the problem, similar to with the variability in mitral valve repair rates, I mean, we're even at a different level with AFib ablation, but I think we're making progress. And I think what we've seen in the last set of guidelines by both the ATS and STS and the new heart rhythm guidelines and the European guidelines for the management of AFib that just came out in 2016, surgery is being mentioned as a 2A recommendation in certain patients. So I think we're getting stronger levels of evidence, and I think we're getting better recommendations, which hopefully will be a continued impetus to surgeons to really try to do this.
So how to do it? I seem to remember you saying that you really had to get, for most effective, get transmural. So there are lots of techniques. There's pulmonary vein isolation, the maze, the biatrial maze. How do you do it most effectively?
Yeah, well, so first of all, I mean, it's a really excellent question. And, I think, first of all, you can't really separate the ablation technology from the procedure you're doing. I mean, in the old days, we used a pair of scissors, and, scissors are easy to use. I mean, you cut it, and you knew when you cut it. But now we're using ablation technology, and the critical thing for any lesion set to be effective is creating a transmural scar that blocks electrical impulses. And we've shown, and others have shown, that even a millimeter or less gap in your line will actually create the entire operation to be ineffective. So you not only have to create a transmural scar, but one that's continuous along these long lesions that we draw around the atrium. So what we've, I think, found in the last 15 to 20 years is We have certainly developed both the experimental and clinical evidence to support certainly bipolar radiofrequency ablation and cryothermy as very effective surgical energy sources that reliably create transmural lesions. And I think they are used in the bulk of the procedures today, and that's improved success rate. The other thing is, what lesion set you do, which is, probably beyond our interview here. We favor the biatrial maze lesion set for a couple reasons. One, it's the one procedure we have, decades worth of data that it is durable and very effective. And that's in patients with organic heart disease. And if you have to remember, most of the mechanistic data we have on AFib comes from the electrophysiologist, which is really all lone AFib. And we're dealing with often a much more advanced substrate with large atrium in patients with both aortic and mitral valve disease. And often they've had long-standing heart failure and developed a lot of atrial fibrosis, which he knows makes it a more difficult arrhythmia to treat. So we tend to favor that, but there appears to be subsets of patients that clearly can have less of a lesion set, and I think we're continuing to learn that.
There are a zillion questions I could ask you, but let me ask you this, and then we probably ought, we could go all night because it's a fascinating subject. What about the patient who has mild left atrial enlargement and has had a few episodes of AFib? So they're not coming into the OR with chronic AFib or multiple episodes of PAF. So the patients had one or two, they've got a little bit of left atrial enlargement.
Yeah, so that would be, no, I think the answer is we don't have good randomized data that most of the cardiologists would like to see to give us a high level of evidence. In fact, there's been virtually no studies. But let's say if that's a mitral patient, which would be your typical patient, who comes in with some paroxysmal AFib and a left atrial size of, let's say, 4 centimeters or less. In those patients, as long as the duration of the AFib hasn't been years, if it's a reasonably short duration, which we would say less than a year or less, those are patients that can be treated very well with just a left atrial lesion set. And when I say that, it's more than pulmonary vein isolation. We would box out all 4 pulmonary veins, the entire posterior left atrium, and then take a line with whatever ablation device you want to take a line to the mitral valve annulus to ablate the left atrial isthmus, which would prevent late left atrial flutter.
So you would do something in those patients?
We would do, absolutely, and we've had excellent success rates, both with just the left atrial lesion set in those and a biatrial lesion set.
And it's safe.
And it's very, very safe. And numerous studies have now shown that adding ablation, whether a full maze or a left atrial procedure, does not add morbidity or mortality. And in fact, the recent paper that I was an author on from the STS database, which is a retrospective, and even though they tried to propensity match it, I think there's still some issues with that. But it actually showed that adding surgical ablation decreased both 30-day and 1-year mortality. Not only did it not add to it, but it decreased it, probably because of the advantages of restoring sinus rhythm.
Well, I think you hit on the magic. Sort of magic word is you have to train the cardiologist, you have to educate the cardiologist, because they don't really, the average cardiologist doesn't think about that. They're thinking, the valve will be done, they'll be okay, or if it's a problem, they'll come back and have, the EP guys do something. And I'm not saying that's not a good strategy, but I think you're right in educating them.
Yeah, and what we've learned in the last 5 years too, Randy, is we've got to educate surgeons. And because of that, we are setting up, similar to the mitral conclave, educating people on mitral valve repair. We've initiated a new meeting called Surgical Treatment of Arrhythmias and Rhythm Disorders.
Cool.
It's joint sponsored by the AATS and Heart Rhythm Society.
Cool.
And we're going to have a 2-day course just teaching surgeons how to do it and how to do it right.
That's fabulous. Listen, you've educated us tremendously, and thanks for visiting with us.
No, it's great.
Thank you.
Great
Thanks
to see you
very much,
again.
Ralph. Thanks.
Take care.
And thank you. Come back and see us again soon.